Hi, this is Geetha Rao. I'm the dietitian, diabetes educator. I work for Palo Alto Medical Foundation, and I deal with a lot of diabetic patients. And today's talk is about the medical nutrition therapy for pregnancy with diabetes. So we're going to discuss a lot about the nutrition and the exercise, the basics of how to manage nutrition during pregnancy. So this webinar is considered a resource, but does not define the standard of care in California. Attendees are advised to adapt the guidelines and resources based on their local facility's level of care and patient populations served, and are also advised not to rely solely on the guidelines presented here. Recommendations are based on the CDAPP, Sweet Success Guidelines for Care. New or updated information is marked throughout the presentation, and I have nothing to disclose. Medical nutrition therapy, as we call MNT, is a key component of glycemic control. So what we're looking at as the goal of medical nutrition therapy, we want to definitely make sure it's more individualized with balanced meal plan, and it does have to be evidence-based recommendations, and it does keep changing, so you have to be up to date on all the evidence. The recommendations have to be evidence-based, and make sure you're getting adequate maternal and fetal nutrition, and also talk about the vitamin and mineral supplementation as needed. Appropriate weight gain is one other important aspect, and I'm going to talk a little bit about that as we go along. Normal glycemia, that's our goal always for MNT, and definitely promoting and supporting breastfeeding. Now, what are the components of nutrition assessment? So there are three components, as you see on the slide: clinical data, psychosocial history, and dietary history. So you want to make sure clinical data, it includes you're looking at the labs and the weight and height, and significant medical conditions that you want to know of which can interfere with the pregnancy. Also psychosocial history, any history of depression or any psychosocial issue that might affect pregnancy outcome. Dietary history, looking at the current eating patterns, any allergies or intolerances to food, history of eating disorder, or lately we're coming along with a lot of cases with bariatric surgery, so that's something else that you want to keep in mind. Because with that kind of a situation, a lot of the nutrition assessment is a little different. Now the goal of an initial dietitian visit. So you're looking at treatment. First thing what you're going to do is initiate the treatment, and you are always going to look at initial individualized meal plan based on the ethnicity, based on the needs, and based on all the clinical data or the assessment that you gathered at the first visit. Also an individualized exercise routine. And many times it comes as a surprise for patients that, oh, you have to walk after every meal. So it would be good for a dietitian to stress that goal at the initial visit. And also patient comprehension. So a lot of the patients you see probably in your setting might already know a lot of stuff because they come in very well researched, but there are some of them where you have to really start from scratch. So you want to definitely make sure what is the comprehending level of the patient, or what is how ready the patients are to absorb the material that you're going to present. And assessment completed, you want to make sure you're looking at the weight gain goals, and also if you're using the weight gain grids, that it's plotted well. As long as you're tracking the weight gain, you're not only looking at the sugars, but you're also looking at what the rate of weight gain or the amount of weight gain is during pregnancy. The preconception goals. All women are encouraged to achieve a reasonable weight before conception. Of course, many times you get patients where there's surprise pregnancies, and here they are, and you have to deal with them. So, but as much as you can, encourage to achieve a reasonable weight gain before conception. Preconception BMI should be used in determining the weight category. And there are a couple of slides that are coming along. I'm not going to go very detailed into that, but as you can see, these are some of the formulas that you want to use to determine the preconception BMI, which is the body mass index. So as you see the BMI, it could be either weight in pounds times 703 divided by height in inches and height in inches. So it's square, height square. Or BMI could be weight in kilograms divided by height in meters and times height in meters. That's height squared. So it's kind of self-explanatory. Now looking at the body mass index or the weight gain goals that's coming in from the 2009 IOM Institute of Medicine guidelines, you're looking at a category, pretty much it's very clear here what you're looking at. So underweight, what you're looking at the BMI, you look at the category on the left-hand side, and then you're looking at the recommended total weight gain ranges for singleton pregnancy and the twins. So you can clearly see the weight gain goals that are listed in there, although we don't know how the recommended weight gain goals for the twins in the underweight category. So we have to take it very individual at that point to see what the baby's growth looks like from the prenatal visit or ultrasound. But if you look at the normal and the overweight and the obese category, the weights are kind of listed in there. One of the things that I would want to say in the obese category, there is what is you look at the new guidelines that came out in 2009 from IOM. The recommended weight gain goal for obese category is still 11 to 20 pounds. So we definitely want to focus on telling the women who are obese to start with or overweight that they still need to be gaining weight. That our intention, we're not recommending any weight loss, although many times their intention is, I lost some weight, that's good for me because I started with a higher weight. So the focus is still on a weight gain, minimal weight gain, which is 11 to 20 pounds. But many a times the women lose a lot of weight as they start changing their diet, and it's perfectly okay as long as the baby's growth looks fine in the prenatal visit or the ultrasound. So that's something as a provider you might want to keep track of with the weight loss with women and how is the baby growing. So it's you got to take one step at a time. So you can't really go by the books all the time, but you got to have to see how everything is connected. The next slide shows the same thing based on the IOM guidelines. So if you're looking at category and the BMI and the mean range in pounds per week for singleton is, I'm not going to kind of read through that, but you can see it tells you for underweight, it's like about 1 pound recommendation or weight gain per week, and for normal, it's about 0.8 to 1. Overweight is about, on an average, is 0.6, but half a pound to 0.7. For obese category, we want at least like about 0.4 to 0.6 pounds of weight gain per week. Now, where can you find the weight gain grid? So you can see the forms are located at the CDAPP website, and these resources are free, and you can feel free to kind of download these forms and use that form. So if your facility does not really use the forms, but you have a built-in weight gain grid in your EMR system, you're free to use that. But this is something, if you wanted to keep it as a hardcore weight gain grid to show it to the patient, this could be a very good education tool. So you can find all that at the CDAPP website, and feel free to download that. And this is just an example of the weight gain grid that you can see for the prenatal weight gain grid is for the pre-pregnancy obese weight gain category, like an example. And you can see this shaded area where it's talking about for the obese BMI more than 30, and then you also have the other categories on the left-hand side, which goes by the height and the underweight, normal, and overweight. So this is a neat little tool, and at the top you can even see the recommended weight gain for single and twin. So I feel this is a nice little tool if you wanted to kind of have it handy and show it to the patients. The but feel free if you think that showing it from an EMR system is good enough too. That's perfectly fine. So, but like I said, these things can be found at the CDAPP website. Now, what are the preconception energy needs? The energy needs are based on preconception weight. So it depends on access to care. Some of the patients come in really, really early, and which is a really good thing because you can really control the sugars and the weight, and you can do a whole lot of stuff, changes in your diet and exercise. But sometimes you do have patients who come in pretty late. It's almost like it's time to deliver. But energy needs always are to be based on preconception weight. So calculating energy needs using the IOM formula, the EER formula, which you can see in the couple of slides coming up, is, like I said, I'm not going to go through the details, but you can see the EER formula for 14 to 18 years old. And you'll be surprised, like sometimes you get the 14-year-olds. Well, I had one teenager who was pregnant with a singleton at 14. So what do you do now, kind of? So we have categorized that into 14 to 18-year-old, and also the second category is from the 19 years or older. Sometimes you're surprised. The oldest, I've had the oldest at 53. Well, surprisingly, I kind of say sometimes people are in the perimenopause or kind of getting there, and they kind of get on metformin and they start ovulating and they get pregnant again. So this is what the category you can use, 19 years or older. And so this is a good one to use. Just going into details about the EER formula, the abbreviations, A being the age, PA being the physical activity coefficient, weight obviously in kilograms, and height in meters. So moving along, the physical activity coefficient. So you can see in the table, depending on the activity level on the left-hand side for the sedentary, which is a light physical activity, or the moderate activity, which is at least 30 minutes or more of intense physical activity, or the active, which is 60 minutes of moderate to intense activity. So you can see it is categorized from 14 to 18 years and more than 19 years. So the PA, or the physical activity coefficient, changes with activity level and changes with the age. So you can feel free to refer to this to use the EER formula to calculate the energy needs. And so the prenatal, like to start with, many of the facilities I know probably might not have as much time to use the EER formula, and you have a set template as to where we start. Normally, what I would suggest at that point is like the first trimester, which is anywhere from 0 to 12, 13 and a half weeks, energy needs are not that great because the first trimester is when the placenta is, by end of the first trimester, is when the placenta is formed. And that's when it starts to release a lot of hormones. So that's where the drama starts with all the sugar. So meaning at that first trimester, the energy needs are not that great. So you really don't need that extra calories coming in. But like I said, a lot of the pregnant ladies are probably coming at 24, 28 weeks. But if you had somebody coming in the first trimester, it's okay to start with the 1,800 calories. That's what most of the facilities do, is that's the starting point. If you didn't have time to calculate the EER formula for energy needs. But you can use that, and but just keeping in mind that you're really not hyper-focusing on too many calories at the first trimester. But as the placenta is formed, the second and third trimester, that's where you see a lot of the energy needs increase, and that's when you want to focus on increasing the energy for fetal growth. Now, what is the energy need for pregnancy? It's based on gestational age. So looking at the IOM formula to calculate energy needs for pregnant women who have normal weight before pregnancy. So as you look at the slide, the first trimester, you're looking at the adult EER, what you calculated from the EER formula, and you have no calories coming in over there. Now the second trimester, but keeping in mind if the first trimester, if you had a pregnant woman who came in with who was underweight, maybe that's appropriate at that point to bump up the calories a little bit. But technically, from second trimester, you are adding in more. So if you're looking at the formula, you have the adult EER, and you know the whole formula as it goes along, plus 160 calories or 8 kilocalories per week times 20 weeks, and you add the extra 180 calories. And the third trimester is where the energy need is the greatest, so you're adding in a lot more calories. But many a times, like I said, this is not a golden meal plan or the energy need. You really have to base it on how the what is the weight gain of the woman, what is the rate of weight gain, how is the baby growing. So you really have to tweak a lot of this as the pregnancy goes along, because you might probably have to do that if the baby is going to way too big. Maybe you might want to readjust the carbs and the calories. And if the baby is going really small, you have to maybe add in a little more calories, more than past 1,800. So you kind of have to, play it by how the whole situation is working. And now the energy needs may require some adjustments, right? And during pregnancy, based on blood glucose values and ketone levels and weight gain parameters. So if someone is having carbohydrate ketosis, their carb intake or energy needs might have to go up. And all the adjustments, that's when you really have to keep in mind also the growth of the baby. So everything is kind of connected. So the first couple of weeks when you actually start the MNT, you might see women losing some weight. And it's normal to see some ketones in the urine, trace amounts, and you see everybody having trace amounts, and that's really not a big deal. But when you're making changes in your diet, that's where you could see a rapid, if you see somebody losing weight really rapidly, maybe that's a good time to do some ketone testing, maybe for a couple of weeks until the weight loss or the weight issue is more stabilized. So that's where you really want to make sure that the person is getting enough carbs, because many a times when you start with the diet, the first thing that women do is they cut out all the carbs. And that's exactly, we don't want them to do that, because they could end up with small to moderate to large ketones in the urine. And as per Sweet Success guidelines, we are not recommending that you have to do your ketone testing every day. But I would take it based on the weight changes and everything. So once the women go through prenatal checks, they are basically having a lot of urine tests and everything going through the prenatal check. And they do test for ketones over there. So I would really not make it a regular routine. But if you suspect that the woman is losing a lot of weight and you think that I really want to check the ketones, that's probably where you can initiate. All right, so moving along, the next slide is the energy needs for overweight and obese women. So this has been in the debate for a long time, and I think it's been clear over time, and a lot of us deal with overweight or obese women before pregnancy, starting into pregnancy, and worried about the outcomes. But there's no consensus on determining energy needs for overweight or obese pregnant women. A minimum is what we start with is 1,800 calories for adequate nutrition, and that should be enough. But you have to carefully monitor all the clinical aspects to make sure there's adequate intake to support the fetus and the mom at the same time. So research has shown that restricting usual caloric intake by about 30 to 33% in obese pregnant women have been demonstrated to prevent macrosomia without having any significant ketones in the urine. So I think this is something that it's okay to try, but you have to monitor the ketone levels at that point, making sure the woman is not spilling ketones in the urine. Now, the macronutrient recommendations during pregnancy. So the calories gradually increase after the first trimester into the second trimester. the protein needs go up. Recommendations are usually 1.1 grams per kilogram per day or additional 25 grams from second trimester. And this is, like I said, again, it's not a golden standard. You might have to tweak it again based on, what's happening at that point with the pregnant woman and the way the baby's growing. The carbohydrates, I need a minimum of 130 grams per day in first trimester because the energy needs are not great, and 175 grams per day in the second and third trimester, right? Like typically we talk about most of the women kind of cut out a lot of carbs the first trimester, so they might actually drop to 150 grams per day. So that's where you want to make sure they are getting enough carbs to support the baby and themselves. Now the fat, focusing on monounsaturated fats as main source of fat. Of course, they're a little bit liberal with fat during pregnancy, but advising the women, just because you're liberal with fat, it's not like you could be doing a lot of fried stuff or lots of other fat, additional fat, but being kind of mindful of what kind of fats. Now the micronutrient recommendations during pregnancy. So the fiber, we encourage at least 25 to 35 grams per day, focusing a lot more on vegetables, and of course we are pushing the fruits too, but you've got to keep in mind fruits have natural sugar, so you're not recommending you can have as many as you want, but generally pushing fruits which are high in fiber. And because pregnancy itself could have a lot of issues with constipation and things, so fiber also helps with that as well as to maintain the sugars. Now the sodium, the average intake for women under 50 years is about 1.5 grams per day. The upper limit is about 2.3 grams per day. So patients with hypertension and nephropathy, no more than 2,000 milligrams of sodium per day, or unless they've been told or advised anything different by the primary care or the doctor, OB dealing with them. So continuing to folic acid, preconception, we recommend about 400 micrograms per day. Pregnancy, about 600 micrograms per day. So one of the things that I do want to say that most of the prenatal vitamins do come about 600 micrograms per day. So we're talking about 600 micrograms of folic acid overall. So if you're getting a lot of food, folic acid from food, that's good, but prenatals do have that anyway, 600. So we're talking here about 600 micrograms for the coming overall dietary and supplement as well. But so 600 micrograms per day should be pretty sufficient. And the history of neural tube defect, if anybody has that, then it bumps up to about 4,000 micrograms per day. A tolerable upper limit for 14 to 18-year-olds is about 800 micrograms per day. And for 19-year-olds, it's about 1,000 micrograms per day. Now, vitamin D. So we're looking at the RDA, recommended dietary allowance for pregnancy and lactation, is based on the IOM report from 2010. It is recommended about 600 international units per day, or 15 micrograms per day. The tolerable upper limit for pregnancy and lactation is about 4,000 international units per day. So one thing to remember about vitamin D is we want to try to avoid mega doses of vitamin D due to the risk of kidney stones. And research has shown that if you are prone, if you have a history of kidney stones entering into pregnancy, you have to be really, really careful about pushing it past the upper tolerable intake. Unless you're coming in with special situations like bariatric surgery, it depends on recommendations coming from your surgeon or your primary care to follow whatever the recommendations of vitamin D dosage is coming from that. But normally about 600 international units should be sufficient during pregnancy. Now, optimum levels of vitamin D is kind of, we've seen a lot of controversial reports on that. So the IOM suggests that if your vitamin D level is about 20 nanograms per milliliter, is sufficient for good bone health. Like every clinic has a different guidelines for what is normal. Most of the clinics I've seen, they say as long as 30 nanograms per milliliter is fine, but the research shows that if you had 20, it's sufficient for good bone health. So a lot of facilities react differently. If they're dropped a little bit less than 30, they might ask them to get into a little bigger dose of vitamin D supplementation. But basically, you have to go with the protocol that you have in your facility. So like one of the 2010 studies shows, at least 33% of pregnant women were deficient in vitamin D using 20 nanograms per milliliter as a target. So especially if you have a lot of Asians coming into your facility, Asians do not absorb vitamin D as well as the other population. So they are typically screened for vitamin D levels, but you want to make sure you are kind of focusing on that, the levels of vitamin D. If someone came with a low vitamin D, you definitely want to address that. The calcium. So calcium, the RDA for calcium and lactation during is from 14 to 18 years old is about 3,000 milligrams per day. 19 to 50 years old or more is about 2,500 milligrams per day. So preferable source is always food. Like we always say, the supplements has to come from dietary sources, but we understand that the pregnancy is, as you get pregnant, the needs go up, so you could ask for a supplementation. And best absorbed form, I would say, is calcium citrate than the carbonate. And 600 milligrams is, in most supplements you can find 600 milligrams. The best absorption happens when you're actually splitting the doses, always, not overwhelming the body. So the absorption is really good. So splitting the dose into 200 to 300 milligrams 3 times or maybe 500, 2 times is always better. And making sure that the calcium is not taken with iron because they bind to each other and the absorption is not great. So if someone is taking calcium and taking iron, we tell them to wait at least 2 hours apart so they're not binding to each other. Now, the vitamin and mineral needs in pregnancy when it comes to folic acid, going again. So 600 is what we talked about, like I said before, per day. Iron, if you're taking 30 milligrams per day, that's what is the recommendation at first prenatal visit. And women taking iron supplements, this is one thing that you got to keep in mind. Someone who's taking an iron supplement more than 30 milligrams per day, they could get deficient in zinc and copper. So it's recommended you take 15 milligrams of zinc and 2 milligrams of copper per day along with that. But if someone is not really, taking less than 30 milligrams, I wouldn't worry about that. So vegans, of course, miss out a lot of the zinc. So if you have vegans, so maybe adding zinc, 15 milligrams per day would be beneficial. And also about 600 international units of vitamin D and 2 micrograms of vitamin B12. Only thing that I would talk about vitamin B12 and a vegetarian and somebody who's on metformin. So, for example, you got somebody from REI, fertility clinic, and a person is either vegetarian or a vegan and has been on, like a pre-diabetic, let's say, and they have been on metformin for a while, and being vegetarian or vegan, being on metformin for a while, you could actually get deficient with vitamin B12. So you want to make sure that a pregnant woman has been started on vitamin B12 supplementation. Now, switching gears to other substances during pregnancy, and caffeine, people ask a lot of questions about, herbal teas and caffeine, and is Splenda okay? So this is something that gives you a good guidelines on what to look at. Caffeine, it is we want to make sure that you limit it to at least to no more than 200 milligrams per day, which is about 2 to 6 ounce cups of coffee. And of course, it's not the Starbucks coffee we're talking about, or the espresso, a normal regular 2 to 6 ounce cups of coffee. And this is based off that no-range study. Birds, only thing people ask me, what about, herbal tea or green tea or anything? So my recommendation would be herbal teas don't go through, safety or the clinical trials through FDA. So we really don't know the safety and efficacy of that. So I would say as long as it's not interfering with your sugar values, I think it should be okay. But you want to definitely make sure that you're letting them know, explaining that the safety is really unknown. So we have to kind of base it on how it's working in terms of your sugars. And some of the potentially contraindicated substances are, ginkgo biloba, ginseng, echinacea, St. John's wort, and a concentrated herbal garlic extract. So all this potentially, like I said, they don't have clinical studies on that, so safety and efficacy still we don't know about that. So what are the substances during pregnancy? So DHA. It's important for the mom and the baby's brain. So it's found in wild fatty fish, like in the category you can see salmon, sardines, freshwater trout, and some fortified foods like milk, bread, and yogurt. So inadequate DHA from food, if it is, you think that, for example, someone is really vegan or vegetarian or in general is not getting enough DHA, you want to think of supplementing containing at least 200 milligrams of DHA. We always, like I said, try to push the dietary sources first. But you see many times when the patients go in, the OBs are giving them, or maybe some facilities do that, giving them an introductory pack of DHA that they want them to get started on. And there are several prenatal vitamins, prenatal supplements that includes DHA already, either from fish oil or other sources. Some of the toxins to avoid. Definitely we want to avoid salmonella during pregnancy, so avoiding any raw vegetables. And you want to make sure you're talking about listeria. So listeriosis is one of the conditions that occurs during pregnancy. It might, look like a normal flu, a viral flu, and people kind of say, it's just that. It'll go, but it actually could be listeria. So you want to make sure that you're avoiding any raw sprouts and unpasteurized milk and cheeses. Usually I say the soft cheeses or the Mexican cheeses you want to try to avoid. Cook all meats, really cook, meaning we're talking about it has to be, the temperature has to be really high for that bacteria to die, because listeria can actually grow in refrigerated temperatures. And so cook all meats, fish and poultry thoroughly, and making sure you're heating deli and luncheon meats until steaming. So it's not like you go for a party and the deli meats are sitting outside and, you kind of, eating that. So that's one possibility where you can pick up the listeria. So you want to be mindful of that. And some of the drugs like the, marijuana included too, and alcohol, you want to be careful, obviously, and you want to avoid all those. One of the things, if you had a patient who is, you have questions about those drugs or anything, you can always contact the CTIS, which is the California Teratogen Information Service website. And they are an awesome website. I would say that if you were actually visiting the website, you can actually talk to a live person and have your questions answered. And also, they talk about everything, A to Z. So I think that's something that you want to keep in mind if you had a patient. Some of the toxins to avoid are the mercury and PCBs, and you want to make sure that when you're talking about fish consumption, you talk about is avoid shark, swordfish or king mackerel or tilefish because of the concentration of mercury and PCBs. Limit other fish and shellfish to only about 12 ounces per week. So 3 ounces is like your deck of cards if you visualize, so about 12 ounces. Canned light tuna has less mercury than albacore tuna. So, but overall, trying to avoid or limit about 6 ounces per week of tuna. So, but overall, you're trying to see that you're limiting fish and other shellfish to about 12 ounces per week. The non-nutritive sweeteners. This has always been a question, although you come across people saying, you know what, is it really safe to take non-nutritive sweeteners? Because they're talking about all these, controversies about sweeteners and, affecting your bladder, affecting your memory, and a lot of other things, carcinogenic. So there is a lot of debate. There's a lot of animal studies going on. But there is something that it's come up. We've come up with something what's called a safe with an acceptable daily intake. So ADI, meaning acceptable daily intake. So as long as you're within that, it's safe to take non-nutritive sweeteners during pregnancy, like saccharin, aspartame, neotame, sucralose. Stevia-derived sweeteners are on the generally recognized safe list, what we call the GRAS list, which is generally recognized as safe. But there is insufficient evidence to use stevia in its whole earth form. So a lot of the women I see, because there's so much to remember, so much to look into that, they say, you know what, I'd rather just not have anything sweet. So, and usually speaking, people, when they do it for a couple of weeks, and they try adding any kind of a nutritive sweetener or sugar back and kind of taste different. So people are generally okay, women are generally okay just kind of letting go of any kind of a sugar or sweetener. So when it comes to agave, so you're looking at agave is something which is natural. It still comes from cane sugar. So it has the carbohydrate and the calorie content, which is similar to a table sugar. It's sweeter than table sugar, so you need very little. It's considered a low, possibly a low glycemic index, meaning the way it translates from your stomach into the blood is really slow. So which is really good for someone who has diabetes during pregnancy. And likely safe when consumed in small amounts. Again, there's a lot of things we have to talk about that there's no extensive study in there to say what amount is safe to consume during pregnancy, but I would say moderate amounts, small amounts. It's not like you're taking it like a whole bottle per day, then I would be worried about it. And likely unsafe, but only thing when it comes to pregnancy, like we said, there's not enough studies. The conclusion from the studies go, oh, you know what, actually it's probably likely safe in small amounts, but they also say it could be likely unsafe during pregnancy due to contraceptive effects that could lead to miscarriage. So it's believed that agave has like a contraceptive effect which could possibly lead to miscarriage. So we don't know yet, but there's a lot of debate on this. So generally it's safe with non-pregnant population, but I would say conclusion of that, if you're doing agave, maybe very, very small amounts. But bottom line, when you're looking at the outcome of the baby, I think it's worth just kind of not adding any sugar or nutritive sweeteners. Now, sugar alcohols and polyols. So this is also a good one to look into. So the examples of sugar alcohols are anything, what I say, which ends with a TOL, end of the word, like sorbitol, mannitol, xylitol, isomalt, and hydrogenated, starch hydrophylate. So these are all the sugar alcohols, meaning sugar alcohols don't get absorbed 100% in your body, but of course 50% is absorbed, so you still have to count that towards your carb, so which I'm going to explain about as to how to read that in the label as we go along in the other slide. So the GRAS, generally recognized as safe, Usually it reduced risk for dental issues. It had a laxative effect. So one of the things about sugar alcohol is if you were to have a lot of any product which has to go like a low sugar, probably it has a lot of the sugar alcohol to preserve that and make it low sugar. If you were to have a lot of food products with a lot of this polyols and sugar alcohol, you probably would end up in the bathroom having, GI issues. So you got to be careful about getting cured of eating too much of sugar alcohol. So half the calories of sucrose. And when you're calculating the carbs of foods containing polyols, you have to subtract half the sugar alcohol grams from the total. Probably it's good to do calculations because then the insulin dosing is going to be more accurate. Now, looking at this chocolate bar with no added sugar, so that's like a trigger for you when you're saying no added sugar, obviously probably would have some kind of polyol or sugar alcohol. So when you're looking at the nutrition facts, when you look at the serving sizes, 4 sections, everything that you're looking at the nutrition fact is based on the 4 sections. When you're looking at the serving per container, which is 2, that means total you have like, 8 sections. So now the amount per serving, so per 4 section, you get about 200 calories. Fat is 15, saturated fat is 15. But scrolling down, the usual thing what you're looking at, sodium is 45, cholesterol is 7. Total carb is, so far it looked okay, but you're looking at total carbs is 27 grams. You're like, then you have dietary fiber. Obviously, this is not a high-fiber food. Any high-fiber food is 5 grams of more fiber per serving, right? And then you're looking at sugars. Then you're looking at the mannitol. That's what is your sugar alcohol. So mannitol, you can see it's a big number. It's about 20 grams. No wonder it makes the other parts of your nutrition facts look pretty good. But now you have to subtract the 20. So if you're looking at the bottom, it gives you that neat little how to calculate carbs. So if you had 20 grams of mannitol, which is a sugar alcohol, so you remember you're going to subtract only half of that from your total carbs. So divided by 2, which is 10, your total carbs, net carbs, are actually going to be 27 minus 10, which is your 17. The bottom line is if you eat 4 sections of chocolate bar, which is 1 serving, you are going to get 17 grams of carb. So a serving of starch is about 15 grams of carb. So when you're looking at 17 grams of carb, I would say I would round it, maybe it's 1 serving of starch. So that's how you do the carb counting on the polyols. I know it's a little complicated, but someone who is really on insulin and someone really wants to know the net carbs, I think this is a great tool. But like I said, if the mannitol was just like 1 or 2 grams, I would not worry about calculating. Now, reading the food labels, step-by-step guidelines, we're going to go with that. We talked about sugar, alcohol, and fiber guides. So fiber is the same thing, like sugar, alcohol. If the food contains more than 5 grams of fiber, that's only when it's a high-fiber food. If it's 1 or 2 grams of fiber, I would really not worry about calculating that from the carbs. So if you have 5 grams of fiber per serving, subtract half of that fiber from the actual carbs, right, to get the net carbs. So, and the sugar alcohol is the same thing. If the food contains more than 5 grams of sugar alcohol, you subtract half the grams of sugar alcohol from the carbohydrate grams to get the net carbs, right? Now, switching gears, this is an absolutely wonderful tool. I use the facility where I work for Sutter Health. We do have a packet for our new GDMs, and this is one of the forms that we use in a packet, and you can download it. It's on the Sweet Success website, the CDAPP website, and it's called the My Plate for Gestational Diabetes. This is the first page. Neat little things. It's just like I tell my patients, it's a cheat sheet for you for your diet. You can look at it. And then you can see the next page, you can do back-to-back copy, and the second page is my nutrition plan for gestational diabetes. It kind of gives you a neat little summary of what you need for eat to lunch and breakfast and snack ideas. So feel free to download this from the website and use it freely in any way you want for your class or for your individual appointment. Now, what are the guidelines? And so you're looking for, these are the basic guidelines for GDM. So if you were doing a class or a first visit one-on-one, what I would talk about is teach the patients carb counting. So the basic of carb counting is 1 serving of starch is 15 grams of carb, meaning carbs are a component of starch. If you take 15 grams of carbs, it makes 1 serving of starch, right? 1 serving, 1 choice, 1 portion, it's all the same. So spreading the carbohydrates load over 3 small meals. Always talk about meal spacing. So talk about 3 rules of thumb: meal spacing, carb spacing, and adding the protein with every meal and snack. So spreading the carbohydrate load over 3 small meals and 3 snacks, right? It depends on the schedule of the patient. And carbohydrates are not really well tolerated in the morning. So the first thing what happens in the morning, maybe anywhere from 2 a.m. until 8:30 in the morning, there's a huge, big, strong surge of placental hormones present. At that point, your body is not tolerating carbs very well, especially there are 2 food groups. One is the fruit, anything to do with fruit juice, jams, jellies, or dairy, like milk, yogurt, buttermilk. People tolerate cheese okay, but you'd have to see one at a time and see how that goes. Cheese, people tolerate, like I said, but soy milk and almond milk is perfectly okay. We're talking about lactose here, right? So for flexible carbohydrate intake with the use of insulin. If someone is on insulin, you can be a little more flexible with the carbohydrates because you can adjust the insulin dose. The fruits, I usually say 2 to 3 servings per day, obviously not at breakfast. And I also tend to say try not having bedtime food as a bedtime snack because it's kind of not about hormones, but it really does not gel very well. So 2 or more, not at breakfast. Milk, 3 or 4 servings per day, not at breakfast. So when I'm talking about milk, it's not just the milk. So anything dairy, like you have, the cheese and the yogurt and the milk or the buttermilk, everything is in the milk category. But someone who is lactose intolerant, you can do the lactate milk. But if someone really is not doing as much milk, we're talking about calcium is still getting from prenatal. So there's no reason to panic because you're still getting it from the prenatal vitamin. And so we're looking at 2%, 1% fat. Like we said, we're a little bit liberal with fat, but 1 to 2% is what we talk about. Someone who's coming with a pre-existing diabetes, pre-diabetes, with dyslipidemia, you have to definitely talk about the low fat. Non-fat is more processed. Personally, for me, I don't tend to push a lot of non-fat because of the processing in there. So I would rather go between 1 and 2%. In portion size of about 4 to 8 ounces during meals or snacks. Now the bread and the starch, as long as how low can you go is like at least 15 to 20 grams at breakfast. And I've had ladies where they're so insulin resistant, so resistant to carbs that they do about 7 grams, 10 grams, they spike. So I've had ladies do as low as 7, but again, like I said, there's no hard and fast rule. These are just the guidelines, but you have to look at what is working for your patient. As long as the baby's growth is not compromised and the women are gaining weight, everything looks, you make the connection. If it looks okay, then it's fine. So you have to take 1 week, 1 day, 1 week at a time. And a minimum of 7 grams, like I said, but 15 to 20. Typically, I start women with 30 grams at breakfast, but no less than 7 grams. and a minimum of 7 grams of protein, which is 1 serving, and about 15 to 30 grams of carb at bedtime snack. Generally, 15 grams works well, unless you see someone is really going low sugars in the morning, maybe probably add a little extra carbs at bedtime snack. Now, refined sugars. You're looking at juices, processed breakfast, cereal, instant potatoes and noodles. So anything that you think about instant should be avoided. When you see instant, meaning it's pre-digested, it's into thin flakes, and it's ready to go. So you don't. It's normally a high glycemic index food. So you want to try to limit or avoid that. Everything you look at has to be whole wheat, whole grain. So in just very simple terms, everything brown is better than everything white. Vegetables. I don't normally put a limit for non-starchy vegetables, or anything other than corn, peas, potatoes, pumpkin, beetroot. Non-starchy vegetables are okay. But if you're eating all the corn and other stuff, potatoes, they're still starch. The more fiber, the better it is, with the sugar and the weight as well. Fats, at least 6 or more portions per day. Limit saturated fat, not like the butter and the logs and everything. And emphasize on monounsaturated fats, the oil, canola oil, avocados are good, nuts and seeds. Avoid trans fats. Obviously, a lot of the food products you see these days have no trans fats, so good to see that in the label. And include, it has to be a very realistic individual meal plan. Like I said, it's not a golden meal plan. You might have to tweak it. What you started at the beginning of the pregnancy, your meal plan could be a totally different thing by the end of pregnancy. Now, the recommendations are to kind of put it in points: 3 meals, 2 to 4 snacks in between. You want to make sure you're eating every 3 hours, no more than 10 hours of gap from your last meal, which could be a bedtime snack, and to the breakfast. Because you got to keep in mind, every pregnancy itself is a starvation mode, period. Anytime you have more than 10 hours of gap or long hours during meal and snack, your sugars are going to kind of drop. And your body's defense mechanism is, when there's a drop in the sugar, your liver has a storage of glucose. It's probably going to rebound to compensate for the lows. And you rebound a lot more, so you're kind of hitting these rebounds all the time, and you have peaks and valleys. That's what you're trying to avoid. So you want to make sure you're more consistent with spacing, eating every 3 hours between meals and snacks, no more than 10 hours a gap from the bedtime snack to the breakfast. So consistency in the schedule, that's what is very important. And synchronize meals, snacks, and oral meds. I know it's easier from the provider's part to kind of put this, but being pregnant, being diabetic, and maybe a lot of them working full-time job, busy schedule, maybe some of them already have toddlers, it's a reality. So that's a reality. So that's where you have to keep tweaking your the diet and see how realistically you can meet the needs. So scheduling and synchronizing meals and snacks is very important. Adequate nutrient intake. So you want to make sure the mom is getting adequate nutrients, and the weight is, she's gaining weight, everything looks good, and the baby is growing as well. And reading labels for carbs, like we talked about the carbs, extremely important, especially for someone who's on insulin or so, and doing insulin to carb ratio becomes much more important. Encouraging pattern management. So it's like you want to make sure that encourage patients get their food records, because that's the only way you can figure out is what did you eat and why are your sugars high and how much of insulin you need to take. So pattern management, it helps you figure out what time of the day your sugar spikes up or what time of the day your sugars are low. So that is the area where you can actually start working on your diet or the exercise or whatever it is, or changing the insulin dose. Now, the foods to limit. One of the things we talk about, anything like we talked about the instant, anything cold, instant hot cereal, It is a high glycemic index food and elevates the blood sugar, so that's something that we want to focus from the start of the MNT. And beverages, avoiding sports drink, energy drinks, drinks sweetened with sugar, high fructose corn syrup, fruit juice. So I usually tell my patients anything, juices, anything that's in a liquid form, try to avoid it because that goes in the blood really fast and you could have a lot of spikes in your sugar. Carbohydrates, it impacts the blood sugar more than proteins and fats. So first thing, if you had lots of carbs, eventually you can see a spike in your blood, and also depends on how resistant you came into the pregnancy. So the recommended dietary allowance, RDA, typically is adequate. What the recommendations for pregnancy is adequate for about 97 to 98% of women. For pregnancy, the RDA for carbs is about 175 grams per day. And lactation, you need a lot more because you are, when the milk is gone out of your system, you are letting go of a lot of calories from your system. So your need goes up a little more than pregnancy, which is at 210 grams per day. So what is estimated average requirement, which you call the year, is adequate for, so when this estimate stats come out, they found that it's adequate for about 50% of women, and pregnancy is about 135 grams per day, and lactation, the estimated average requirement is about 160 grams per day. Like I said, it depends on the individual need. So you might have to go up a little bit more on lactation depending on how many times you're breastfeeding, versus if you're not breastfeeding at all, then you don't need the 210 grams per day. Now, the sources of carbohydrate include starch, which is, usually say everything that tastes good is pretty much starch. So the rice and the pastas and the cakes and the pies and the crackers and tortillas, all the yummy stuff. And the fruits, fresh fruits, dried fruits, fruit juices, jams, jellies, everything is starch. Milk, milk and yogurt and buttermilk, all that is starch, but it's also protein. Soy milk, you got to read the label because some of them are unsweetened, some of them are sweetened. Vegetables, make sure you're emphasizing a lot of dark green leafy vegetables. Sweets, desserts, and carbs, obviously the cakes and pies and everything is refined carbs coming in there. So now this is exchange, I think pretty much, if you're a dietitian, probably this is something like you've seen it all through your life. But this is an exchange information. I'm not going to read through everything. Basically, on the left-hand side, it's telling you the groups of starch, fruit, milk, and vegetables, and meat and fat, and it tells you how many grams of carbs and protein and fat and calories you get from this group. As you can see, the starch gives you the most of the carbs and the fruit and the milk, and vegetables, some of them do have 5, but if you, like I said, if you're doing the starchy vegetables like corn, peas, potatoes, pumpkin, you probably get the 15 grams. And the meats and fats don't have any. So this is a good, neat little exchange information that you can have and also give it to the patients. Now the serving sizes. So what are the serving sizes? This always kind of throws out everybody. So serving size is one starch is like one slice or 1 6-inch tortilla or 6 saltines. Or a milk, one milk is about 8 ounces of milk, 1%, 2%, does not matter. 3/4 cup, but definitely look at the label. 3/4 cup of yogurt, right? No sugar added, definitely not the flavored ones. We're talking about the plain yogurt. 1 fruit, usually like a size of a tennis ball, is 1 small fresh fruit. Cut up usually maybe like about 1/2 cup to 3/4 cup. So 1 carb, you can trade off. When we talk about carb counting, 1 carb is the same as 1 bread, 1 milk, 1 fruit. All of these give about 15 grams of carbs. Now, label reading, as we talked about, always look at the serving size, look at the total carbs in grams, look at the fiber, calories, and the fat. Now, looking at this label, this is a whole wheat bread example, like you're looking at the left-hand side, always looking at the serving size. One slide here, it says 38 grams. And always look at whether it's low in fat, which is highlighted in the midsection. It's got 1.5 grams of carb, fat, and then which is really not that bad. And then if you wanted to really know if it's low fat, you take on the extreme left total calories of fat, which is 10, divided by total calories, which is 80, and times 100, it should be less than 30%. So in this case, it's kind of low fat. So obviously because it's a whole wheat bread. And then you go down to the fat and cholesterol. The cholesterol is 0. We don't want more than 300 milligrams of cholesterol per day. So this is a good product. And then you scroll down to the diet fiber. So anything that is got 5 grams of fiber per serving is a high fiber food. So in this case, yes, it is a high fiber food because you see 5 grams of serving of fiber per serving. If it is 1 or 2 grams of fiber and it says high fiber on the cover, I would just like ignore that because it's just a marketing thing. You really have to flip the side and look at the reality. So it's always good to kind of look into the label when you're actually counting the carbs. Now the guidelines usually go about as breakfast. This is what typically is the guidelines, but like I said, every clinic has a different protocol. The breakfast could be anywhere from 15 to 30 grams of carbs, which is 1 to 2 carb choices. Remember, one serving is 15 grams of carbs, so 15 to 30 is 1 to 2 carb servings. Or the lunch could be 30 to 60 grams, which is 2 to 4 carbs. Dinner is 30 to 60 grams, 2 to 4. Snacks are 15 to 30 grams. So where in my facility, we try to use, or personally I like to use, is to start with 30 grams at breakfast, 45 at lunch, 45 grams at dinner, and then do the 15 grams only at the snack. So that's the starting point, and then you have to look at how the sugars are looking, what the weight looks like, how the baby's growing, and then you can tweak the diet based on the need. Now, this is just another good table, distribution of carbs, anywhere from 175 to 180 grams, which is 12 carb choices. If you look at the extreme left, it says the food groups, and then you have the 6 small meals. We're talking about the breakfast snack, lunch snack, dinner snack. And the total, when you add it up, you get 180 grams of carbs. So if you want to use this tool, feel free to do that. So typically what I am doing in my facility, I'm doing like a breakfast is 30. So it kind of adds up to the same thing, but the bedtime snack is about 15. Rest all is the same. So it comes to about 175 to 80 grams of carbs. And you can see how you have 12 carb choices. So meaning if you take 180 divided by 15, you get the carb choices. And starches, you can see in the red and the extreme right, the total. Fruits are 2, dairy is 3, lean meats are 13, like turkey, fish, chicken. Vegetables are 5, and fats, moderate amounts. So you got to take the 12 carbs and stretch it out like a slinky into the 3 small meals and 3 small snacks. So it's all about again, the 3 rules of thumb: meal spacing, carb spacing, adding protein with every meal and snack. That is something that you want to keep emphasizing with the patients. The glycemic index, it's an extremely good tool to use if you think you have time in that, the session that you have. But I would say it would be a much more important tool if someone was on insulin, on medication, counting insulin to carb ratios. So I would highly encourage you using this. So when using the low glycemic index diet, meaning you're reducing the need for insulin in women with GDM. And no compromising, there's no compromise of obstetric or fetal outcomes with this. It is very well tolerated, and examples are like sweet potatoes versus white potato. So if you're looking at a white potato, it could be 15 grams. If you're looking at the sweet potato, it's 15 grams. But the way these two foods react in your blood are different, meaning the white potato is probably going to spike like crazy and crash down. sweet potatoes go a little bit slower in your blood and come down a little bit slower. So it's more sustained release, what I call, than spike and crashing down. That's what we call at the glycemic index. But one thing very, very important to note that if people say, oh, the glycemic index food, so I can eat tons of sweet potatoes. That's where the trouble starts, because you're eating a lot of sweet potatoes. We're not only talking about the glycemic index, but we're also talking about the glycemic load. So if you're eating a lot of foods with low glycemic index food, your sugars could still spike. So you've got to be careful, mindful of the glycemic load as well, which is the portion size. Now, what about fats and protein? Fats, we all know, slows down stomach emptying. So I usually say to my patients, if you keep your bedtime snack a little bit high protein and a little high fat, it helps you through the day, overnight when you're sleeping, because it's keeping, that's the longest you're sleeping without eating. So there's a slow, sustained release of sugar overnight. So that kind of helps the sugars at fasting. So fats helps you slow down the stomach emptying, and that's exactly is helpful in your sugar control and potential a source of excess calories. But we're talking about moderate fats. We're not talking about, eating, blocks of butter or something, so there you can start gaining a lot of weight because it's a lot of calories coming in. The proteins, insulin secretion is pretty similar to carbs, but you definitely don't want to start breaking down your proteins for energy, because carbs are the basic fuel for your body. And glucose from ingested protein does not appear in general circulation right away. Well, research shows that about 55 or 56% of the protein after 2-3 hours, it just kind of shows up in the general circulation. So what it means is, if you had a food which is high in protein, the protein is a big molecule. It holds the food in the stomach for a longer time, and it kind of releases after a couple of hours. So that's where you see a lot of the sugar coming down after, which I showed you in the other slide, right? Okay. All right. Sorry, going back. Okay. So now, goals of reassessment. So what are we looking at? So to kind of go back and summarize as to what we have learned till now, we definitely want to monitor the weight gain and make sure it's within the recommended intake. If someone is gaining weight too fast, you want to make sure you're looking at the diet, what are they eating, maybe excess calories coming from somewhere, or it could probably be even preeclampsia. How is the blood pressure? Are they dumping protein in the urine? If you suspect anything, you definitely want to refer them back to the OB so that they check them out for any preeclampsia happening. But we definitely want to monitor the weight, not only the amount of weight gain, but the rate of weight gain. That's something that you want to keep assessing throughout the end of pregnancy. And a balanced meal plan, that's one of the biggest goals, is are they meal balanced? Because some of the patients kind of, it's towards my end of pregnancy, now I can eat whatever I want. But you want to re-emphasize the fact that it's still very important to follow a balanced meal plan and check your sugars as suggested till the end of pregnancy. You have a lot of ladies, examples, last 1 or 2 weeks, you started them on insulin because of sugar control. So you want to make sure you're kind of emphasizing the fact of a carb and a protein balance in the meal. And a meal plan comprehension, making sure they're understanding the diet, and it's a big learning curve. So food is a complex thing, and you learn a lot about food. So as you go along, you want to make sure the patient is understanding her meal and why are we changing it, why are we adding this, and why are we doing this kind of thing. And making sure that you're scheduling appropriate appointments. Appointments always depend on your facility, how many appointments you're allowed, or based on the insulin needs, or based on your staffing. So making sure that the patients are still followed Let it be physically or maybe through telephone encounters or maybe through email, making sure you're there's a constant follow-up with the patient. And weight gain measured and plotted all the time. Let it be as a weight gain form or in the EMR. And always want to make sure the first couple of weeks that you start the MNT, there is going to be a little bit of weight loss during that because of diuresis. Because when you start fine-tuning your carbs, there's water molecule attached to carbs. So when you fine-tune your diet, you lose a little bit of water, and that shows up as weight loss. But past 2 weeks after MNT, you should start to see some weight gain. So you want to first, when you meet the patient, you want to let them know weight loss is really common, and obese and we are on the same page, so and not to panic. So that kind of puts them at peace. And food intake patterns, making sure you encourage them to bring in the food logs and the blood glucose logs, and making sure any comments they have for themselves to why they had a spike. And ladies are pretty good about putting comments saying, oh, I went out and ate, I had a baby shower, a birthday party, or so that kind of explains, and you can talk to them in detail about that. And also comparing with the original meal plan. So many times patients come back and say, I used to eat the same thing in the beginning of pregnancy, but how come this is not working now? So you got to really have to talk to them saying, as you advance in pregnancy, from the end of first trimester to 37 weeks, your insulin resistance is climbing. So you can expect your sugars to actually climb along with that. So you want to make sure you're telling them why you see the same food is reacting differently. So these are all the components you really want to do in every reassessment, every follow-up that you're looking at. So this concludes. I know there was a lot of information on MNT, and it's a hard topic, and it's a difficult one to talk about diet, and it's very difficult for the patients to do. But hopefully this tool will help you the provider's guide in an efficient way in achieving better outcomes. And I really thank all of you for listening to me, and have a wonderful day.